right. Hi, everybody. Welcome back to another episode of RetFix and Chill. We have two awesome guests today. We have Mammo and Ananth Sastry, both from the Cole Eye Clinic in Cleveland. We're going to have some interesting discussions about uveitic surgery. Ananth, if you'd like to start us off.
Certainly. Thank you so much for having us. All right. So I'd like to start off with an interesting case. So this is a 54-year-old gentleman who was referred for evaluation of iritis in his right eye. He had a pathological history of hypertension and no significant review of systems. And he had presented to optometry initially with a 2-week history of progressively cloudy vision in the right eye. So his anterior segment exam was significant for visual acuity of 20/80 in the right eye, 20/20 in the left. You can see that he's got 2+ keratotic precipitates, 1+ cell and flare, and 3 to 4+ anterior vitreous cell in the right eye. His dilated fundus exam is significant here for the right eye with a lot of vitreous haze. And this was in a satellite office where we did not have access to wide field imaging, as well as some creamy subretinal lesions in the macula in the right eye. And the left eye was within normal limits. Here is OCTs. We can see that he's got some sub-RPE large lesions in the macula in the right eye, and the left eye is grossly unremarkable. So starting out from here, if you get a patient like this, what are you inclined to do? How would you start your workup, and how would you want to manage this patient initially?
This is an older gentleman with these suspicious lesions. Your mind is probably, all of our minds are probably jumping right to a vitreoretinal lymphoma picture. But you want to kind of take a step back and figure out if there's anything else you might be missing besides that. The OCT kind of showed these aren't granulomas, but if you're just looking at the fundus photo, you want to make sure this is an inflammatory lesion. You want to rule out infectious causes. You want to get a oncologic and past medical history from the patient. And if all that comes back unremarkable, then I'm probably going to look to see if they had any recent MRI, any LP that was done. I'll likely order the MRI, but I usually don't wait to get the results, to be honest. By the time it gets done, I'm probably going to jump and go ahead and sign this patient up for a diagnostic vitrectomy. Because of the locations of these lesions, I'm probably going to start with just a vitrectomy and not do any biopsy. But if these lesions were elsewhere, I might consider taking the lesion as well, as we'll talk about later. But given how close these are to the fovea, I would just do a vitrectomy at this point.
And so that's exactly what I did. Initially started with basic uveitis labs with syphilis, TB, sarcoidosis. And then actually signed up the patient exactly for diagnostic vitrectomy. The patient did not have any known past oncologic history and had not had a previous MRI, so that was ordered as well. When you're getting ready to do a diagnostic vitrectomy, what are sort of the things that you want to consider going into the operating room before you start your surgery? What's sort of the preoperative planning that you want for this?
Yeah, I can take that. So first thing is you got to make sure that you have good communication with your cytopathologist. A lot of times, if you're sending specimens, it's got to be done fresh. So it's very important that they are aware that this case is going to be done and that they actually know what you're looking for. So that's kind of one of the main important things. Oftentimes, these patients will come to you previously on either oral or topical steroids. So it's worthwhile to give them a little break for that. So, you can let that wash out. That can depend on strategy, but I mean, at least a couple of weeks to let some of the cell come back, at least that you have something cellular to work with. So that's sort of just setting up. Mike, what do you typically order?
So I communicate with the pathologist ahead of time, and I do feel that sometimes it does vary depending on who you're talking to. So in my experience, most of them will actually just prefer it fresh, but sometimes they'll ask for either some component in Cytolite or some component in RPMI for flow. I'll have a discussion about kind of how suspicious I am, basically, and that'll sometimes determine what they'll end up doing in terms of testing. So I don't necessarily go straight to ordering things like MYD88 every time. Sometimes I will, sometimes I won't. I'll send always for cytology, always for flow. I won't always do rearrangements and things like that, depending on, how suspicious we are. I think MYD88 is very nice to rule in and just going to rule it out if it's negative. But that's kind of where I start.
Danny, what's your thoughts on interleukin ratio? Do you use that?
Yeah, it's nice to read about. It's very academic, but I feel like not many are ordering in real practice. I mean, I don't even know where I would send it for that. I don't get it. I'm very similar to Mike. Cytology and flow for sure, in Cytolite and RPMI. And then MYD8 can be valuable, but it's positive about 75-80% of the time. So 20% of the time can be a false negative. And then it can also actually be positive in cases with significant inflammation too. So false positives can happen as well. So, this is a very difficult thing to diagnose sometimes. So we're always looking for this holy grail, but there really is no one perfect way. I find cytology and flow still to be the best and most reliable.
Yeah, I totally agree. So I pretty much approach it the same way. As you mentioned, you want to have good communication, not just with your cytopathologist and, your diagnostics team. You want to also speak with all the OR staff, to have all of the materials ready. You want to have ice available. So that way, when you put your sample into your RPMI or your satellite, it goes, in ice very, very quickly. The way I was trained to, as soon as this is obtained, you want to get it over to the lab as soon as possible because you want the sample to be relatively fresh. So depending on the case and how quickly I think we're going to be able to do it, I will sometimes, fortunately at a place where we train fellows, I will sometimes actually have the fellow run it directly to the lab, or I'll take it myself to the lab, even in the middle of the case, before we're finished, to make sure that we get it there in an expeditious manner. Similar to what everyone said, I don't typically get IL ratios, nor do I get really MYD88. I have heard some reports that those ratios can be effective sometimes when you're following patients up postoperatively, when you're considering potential recurrences, and if there's a concern about that, that can sometimes be effective. But you have to know exactly the labs and that you're sending it to that can process it effectively. So for those who may not be familiar, you go ahead and disengage the aspiration line and connect it to a syringe. I typically just use like a 6 cc syringe. And so here we're starting the case. Now, one thing that is somewhat controversial sometimes is people will talk about, whether or not to prime the infusion line, to not prime the infusion line. I just go ahead and prime it. I've not really found that there's a real issue with having it primed. One of the classic teachings is that you want to not prime it. And when you do your initial undiluted sample, no infusion can be running, no infusion fluid can be running, and you want to get as much as possible before the eye just completely collapses, and then you open up the infusion. I've since moved away from this. I've found that you can oftentimes get a very good sample even with some partial dilution. So what I tend to do is I will aspirate as much as I can. Once it starts to collapse a little bit, I'll just kind of flash the infusion line a little bit and kind of pulse it and then go back to aspirating. So it's perhaps, your initial sample is going to be partially diluted. And generally that's perfectly fine. If you have a good cytopathologist and a good, flow cytometer that you have access to, you can generally get a pretty good sample that way. And so, yeah, just kind of reforming the eye here, and then before going for more. Now, so I usually start with this. One of the things that sometimes people can do is they can consider doing it under air. That's a perfectly fine way of doing it as well. I tend to say that you want to do that for pseudophakics. Now, here is an interesting process here. So I always, induce a PVD. This patient did not have a PVD. The hyaloid was attached. Now, one thing that's interesting about this is that it's generally considered suboptimal if there are steroids in the eye, if you're doing a diagnostic vitrectomy. But I'm just using it for the sake of, lifting the hyaloid. Now, one thing that's interesting about these cases is that the posterior vitreous cortex that's attached to the retina tends to be sort of the highest yield vitreous that can have the lymphomatous cells in it. But I found in my experience that sometimes even when there is steroid in the eye, you can still get positive samples, as was the case in this patient. And I've actually had other patients where they had been injected with Kenalog or Triesence because, by another provider, because they were thought to have pars planitis or some other type of inflammatory uveitis. And it had been sitting there for a while. And, doing a diagnostic vitrectomy, even with that in the eye, I was able to get a positive sample. So here just doing some peripheral vitrectomy, and all of this I'm still collecting sample. And then once we do that, we just switch to the infusion on and doing depressed shave 360. And I'd found a small area of suspicion where I thought maybe a small tear where we had elevated hyaloid. So lasering that and then just going to air. Now, when you're closing up, there's sometimes the question of, do you suture these or not? Is it okay to do unsutured? I think it's perfectly fine to do sutureless in these cases. This is not like retinoblastoma or choroidal melanoma, perhaps, where you want to like double freeze cryo your sclerotomy sites. The lymphoma cells tend to be sort of wimpy when they're outside of their where they normally live, and it's not common that they'll survive outside of the eye like that, or in the subconjunctival space. I've never really seen a recurrence or anything like that occurring in that area, from this. So, just wanted to ask anybody, do things any differently? Any thoughts on the technique? How do you guys generally approach these?
I have a question. I mean, I think it's really impressive that you barely turned the infusion on, even while you were inducing the PVD and doing the 360 shave. In my fellowship, when I did undiluted vitreous biopsies, I did them under air. And I agree, when you do that in a phakic patient, the view goes to crap pretty quickly. And it's hard. I feel like, yeah, you're getting quote unquote undiluted sample, but the problem becomes that you end up, like, I feel like getting a lower yield because you're trying to be safe, and your view is completely warped. I think it's great that you're able to sort of control the infusion and get a really, if you
Well,
include,
you turned the infusion on halfway through, right? You were fully on.
Yes. So after I had done that initial kind of core where you're just kind of cranking things up, at the end, you're still going to adhere to some of these principles of vitreoretinal surgery. Yes, in an ideal world, it would be nice to be able to just go directly to the nerve and, lift the hyaloid and get the, induce the PVD and get that posterior vitreous cortex that's attached to the retina totally undiluted. Realistically, that's somewhat challenging to do. And so,
Yeah.
so I go ahead after I do that initial core, again, flashing the infusion on and off. I just go ahead and turn the infusion on, and then and just do the rest of it. But I'm still aspirating and doing a diluted sample while I'm doing it.
And do you separate like labels, like this is undiluted, this is diluted? Some people send the cassette. Do you do all that?
I don't send the cassette anymore. I found that's generally not necessary. And, with the cassette, it tends to be so diluted out that ends up being, I think, a little too dilute to be useful. But I think if you're really staying in vitreous, that's the other thing. I'm usually doing this. One of my excellent fellows, soon-to-be partner, Rachel Downs, was doing the case there, and I'm holding the plunger and aspirating while she's doing it. But I tell the fellows to once you have cleared out the vitreous in a particular area, move to another area, because I'm trying to stay in vitreous as much as possible and not just aspirate BSS. And I find that if you're doing that, with a dilute and undilute sample, I do separate those out. I find that that's generally sufficient to get an answer. I don't send the cassette anymore.
Most of the cases I've done have been pseudofixed with the hyaloids already up. So it's nice to know you can put a little stain in there. You can get a sample even in younger patients. And there's also, I believe, kind of a demographic shift where we're seeing a lot of PVRL and actually in younger patients. So we do have to be able to do that. Any comment on like your cut rate during this? Are you low, fast? Does it matter?
Yeah, that's a great question. I had been classically taught that, doing a low cut rate, like 1,000 cuts per minute, you can have better morphology, less damage to the cells. I haven't really done that anymore. I mean, I just do it at the regular cut rate, and I've still been able to get positive samples from that. And so I'm not sure if a real study's been done to show whether or not one is, necessarily superior, but I don't do that anymore.
I'm going to give you guys some real talk. We all have complications in our cases, and I just had a diagnostic yesterday and breathed a nice sigh of relief this morning. My fellows, my post-op day one. I did it for C. acnes, and also have been much less stringent doing these undiluted samples. I also sent for cytology. Our cytopathologist really looked at all of our patients that got diluted versus undiluted and really didn't see a difference. So, however, though, yesterday, the fellow, when we started doing it, really wanted to get undiluted specimen. I'm talking to the circulator, trying to get the cytolite to come over to me. And I got just slightly hypotenuse, not anything crazy. And sure enough, complication never seen before, subretinal hemorrhage, temporal macula, all from like a decompression retinopathy. I'm thankfully spared the fovea. Patient looks fine this morning. But I think these things like operating under air, being adamant about getting undiluted specimen, these things aren't dogma. These are things that were passed down from people, and adhering to them and going away from maybe getting to the real point of what to do the surgery. I mean, Steve Charles does vitrectomy under air. How many of us actually do? Like, I've seen more complication videos of people trying to like operate under air and do stuff they're not used to doing than just doing their straightforward vitrectomy that we're all good at. So I think knowing in our field what's dogma, what's not dogma, and knowing that you can still get positive yields, doing a semi-diluted specimen helps you avoid other pitfalls and complications.
I totally agree. I think a lot of the voodoo that's been passed down is ophthalmologist based. If you talk to a pathologist, at least in my experience, They don't care. They can do a gentle cytospin. It doesn't matter if it's a little bit diluted sample. They don't need like PFO in their sample. That's like totally crazy to me. If you talk to like even the older generations, a lot of them are like, why would you put PFO in the eye? The air thing, I agree. It's probably more risk. I do for my cores, I'll do a low cut rate, like a 400 cut rate just for the core, and then I'll increase it when I'm going out the periphery because I don't think that really risks anything to be doing the central core at a lower cut rate. But all the other stuff I think is a nuisance, maybe adding more risk to the procedure and probably not doing anything helpful in terms of the pathology.
All right. So getting back to the case.
Danny, that must have been stressful. I applaud you.
Yeah, I've never seen the. I mean, I've heard about decompression or anopathy, but I've never seen it like live. Eyes one way and then a little hypotenuse, then boom, you see these hemorrhages. But
These are from like
I
the
think it was
deep
okay.
venous plexus of the retina. Where's the bleed coming from?
I didn't know you. I know, obviously, you can get choroidal hemorrhage from hypotony, but I've never seen a subretinal. I had to confirm it with intraop OCT, and it was for sure a subretinal hemorrhage. I'm not sure, but you're probably right.
Were they a myope, by the way? I mean, I wonder, like, if I was, like, it's those like lacquer crack related vessels, maybe
Yeah,
if it's subretinal. It's
yeah,
interesting.
not a myope. History of old non-ischemic RVO. So we had mild peripheral hemorrhages, but post the hypotony, they just way more.
Never a dull moment, bro.
Never a dull moment. Always learning. Always learning.
Yeah, so tell us what you found.
All right. So all of the initial uveitis labs were negative. We actually knew this going into the surgery. Obviously, we would have not proceeded with the surgery had syphilis turned out positive. But the diagnostic vitrectomy was positive for large cell lymphoma. B cells positive for CD19, 20, and 200. And so subsequently, the MRI that had been ordered, brain in orbit, was negative. Despite this, I always get these patients plugged into oncology and ensure that like a lumbar puncture is done. Because there can be some microscopic disease in the CNS that's not captured by the MRI. And we also know that any patient who's got primary vitreoretinal lymphoma in just the eye has about a 40 to 50% chance of developing it in the CNS within 5 years. And our neuro-oncologist, who's excellent, is also, generally great about getting a PET scan on these patients as well to make sure there's no, extra axial disease that's present. And that was negative as well. So now that this has occurred, if you get a patient who's got, PVRL, it's one eye. There's no, I left out, the left eye was, looking totally normal up until this, so far. No CNS disease. How are you generally managing these patients, or what's your general go-to? And would it be different if the patient had both eyes positive, or there was disease present in both eyes?
Yeah, well, I mean, probably our oncologist here might have better answer. But for me, if it's both eyes, that's like a no-brainer. Systemic treatment is what I prefer. If they have very active disease that I really want to melt these lesions away, if they're macula threatening, I'll add on methotrexate to make them see better faster. For unilateral, I will do methotrexate, intravitreal methotrexate for sure. I have some great mentors, and I've heard so many stories about like cases where someone was treated locally and then years later something popped up in the recesses of the brain somewhere despite a negative MRI brain. Those cases always scare me. So I always prefer if a patient also gets systemic on top of it, but I leave that up to the oncologist. I find that some oncologists will still treat, some won't, and it's always a discussion with the patient too. I don't know if Mike has any different experience.
I think you hit all the main points. I'll usually do intravitreal methotrexate. I think maybe one time I had to go under Tuxin, but usually not. Methotrexate, in my experience, works quite well. I think it doesn't need to be dosed as frequently as we sometimes talk about. I think every 2 to 4 weeks is adequate for most patients. In my experience, I think bilateral disease, like you mentioned, is CNS disease. So that can be a tricky conversation with the oncologist. Not every oncologist understands that like there's only one thing that really connects the two eyeballs, so they're not having like a 1 in a million change independently in the two eyes, not like a 1 in billion patient that they just need treatment. I've had patients actually die because the oncologist didn't go on to want to do treatment systemically when I was adamant that they wanted to. I had a patient not too long ago, Western downtown oncology wanted to treat, and they got a second opinion actually at Sloan Kettering that said we can just watch it, and they watch it and develop a brain lesion that she died from not too long after. So these are, this is real disease. So I don't mess around with it too much. Like you said, I prefer when I think there's suspicion for systemic or CNS disease that it be treated.
Ananth, intravitreal methotrexate quick, what's your technique? How do you avoid corneal complications?
Well, that's okay. So that's strong foreshadowing for what's about to happen later. So my technique, it's a little different. It's somewhat similar to what one might do for, for PVR type of methotrexate. The only thing that, I will lay the patient completely supine. I will use a speculum in these cases. I don't normally use specula for regular intravitreal injections, but for this I do. And I have a eye rinse ready pretty much immediately. So I inject in my usual location, for me, that's usually infratemporally. I do, subconjunctival lidocaine. And what I like to do, I do this actually for all of my injections anyways, but I think this is particularly helpful for something like methotrexate where you don't want it to leak out of the eye, and particularly because this is a vitrectomized eye where it's more likely to do so. I'll tend to have a little cotton tip, and as I inject, as I'm pulling out, I'll roll the cotton tip over the injection site to kind of provide like a little plug to minimize any reflux of the medication out from the eye. And then after that, very, very liberal and extensive rinse. Unlike for the PVR situation where you keep the patient supine for like 30 minutes afterwards, I won't do it like that for that long because there's no silicone oil or anything like that it needs to, sink down below. I might have them sit there for a couple of minutes and then usually I'll send them on their way. Now, generally what I will recommend for these patients is aggressive lubrication, usually in Q1 hour artificial tears. And the type of artificial tears actually really matters in this case, as I'll show in a minute. But in terms of frequency and sort of the dosing, so there was a paper, the original paper that was written, I think, by an Israeli group had a pretty extensive and aggressive regimen, which was like twice weekly for 8 weeks or something, to that effect. I have not, some recent papers have been published now from Taiwan and China that show that they've been able to achieve effectively the same remission rates with a lower injection frequency. And so what I've usually been doing is weekly for about 2 months, and then I will start to space them out to every other week for maybe another 2 months, and then I might do a couple of monthly injections after that, and then I'll wash them. If I see something coming back, then I would consider, re-injecting at that time. Of course, throughout this entire process, we're making sure that, they're maintaining surveillance with oncology as well and getting scheduled regular MRIs. So going back to the case real quick. So here's how the patient looked, on post-op week 1. So we went ahead and we had these results and administered our first methotrexate injection. It's exactly what Danny talked about. 2 weeks after that, after his second methotrexate injection, we can see that there's the resolution of that, creamy lesion there. Here's how it looked on OCT. Had improved from 2080 to 2040. The sub-RPE lesions have pretty much flattened out. So patient was doing really well until post-op month 3 after getting a bunch of these injections, and vision has now declined to count fingers. There is a very hazy view, poor signal on the OCT, and basically there's now this 3 to 4 plus punctate keratopathy. So we're at this point, what would you like, how would you want to handle this at this point? The patient's taking Q1 hour artificial tears.
I don't even know, man.
New York's best dry eye specialist.
Listen, ain't nobody got time for listen. I don't have patience to deal with like a poor view. So I'd be like, okay, guys, I'm gonna send you to Nitish so he can take care of the cornea with the cornea specialist. No, I mean, I would consider adding other like dry eye things. For example, punctal plugs and things like that, like aggressive lubrication. I like to add Miro when things get really there's a lot of keratopathy because sometimes drying the cornea can help a little bit. But I'd probably make sure I have a cornea specialist on board. Another thing to consider to get some more rapid improvement, you can put in an amniotic membrane if you have access to that.
Yeah, I think this is probably dosing interval based because I honestly haven't really had much trouble with this in my experience. So I dose it less frequently. I think that's probably what leads to this. And you see these patients respond very quickly. And I've never seen one rebound in less than like 3 weeks or so in terms of like findings where it's like I feel the meds wearing off. So I don't really know that we need to be doing it so aggressively. So I'd probably be backing off on the injections a bit there. Another thing to think about, I usually don't talk about it too often, but the concentration can be helpful. Sometimes if you're getting a lower concentration, you have to inject a higher volume. You might get more reflux. So usually you can get like a 200 per 0.05, and I feel like there's probably less reflux. You might be avoiding getting more on the surface and causing issues like this. But at this point, you guys probably have like 14 cornea specialists or something that can help with the dry eye component of it, but you just got to treat the retina side.
Yeah, another tip I learned was you can AC tap the patient before the methotrexate injections, so they're a little bit soft, and so it won't reflux as much.
But I did exactly what you guys said. I held off on additional methotrexate and referred to the cornea service. Actually, apparently, this is what did it. They just switched him over to preservative-free artificial tears, and I honestly had not been really checking what kind of artificial tears. Had been using non-preservative free. Also, added a tegaderm pathin erythromycin, and it completely cleared it up. So at post-op month 6, has remained disease-free, and is 2025 and has been doing great. That was actually kind of an interesting learning experience for me. To see that vision change and to see how severe it was kind of alarming. And just seeing that switching to preservative free made such a huge difference was very interesting to me. So now for my PVR cases, for my PVRL cases where I'm doing these injections, I now keep this in mind.
It's fascinating. You got to talk to your patient. You got to tell them to bring their drops to clinic and look at them. So thank you so much, Ananth. That was a fascinating discussion. And we'll move on to Danny. You have another interesting technique you'd like to share with us. Do you want to take the mic?
Sure. So yeah, for part 2 here. So, Ananth gives a great job of doing a diagnostic vitrectomy, but sometimes you need to do more. Either you have a high suspicion at the beginning of treating the patient that a diagnostic vit might not be enough. Maybe the patient's in really bad shape and you want the diagnosis as quick as possible. Usually when we're doing a diagnostic vitrectomy, it's because we don't know what's going on. Patient's vision's getting worse, or maybe their systemic health is getting worse. So sometimes you have to go straight to the retina or subretinal space. And there's really 2 ways I do this. One is a dissection, or one is just going in straight in with a cutter, kind of our retina surgeon version of a fine needle aspirate. So yeah, I can talk about those techniques today. It basically comes down to multimodal imaging for me and how I decide which of these 2 techniques we'll go through today that I decide to do. So you don't have to have intraop OCT, but you can just do your, pre-op OCT. And these are both patients that were positive for vitreoretinal lymphoma, non-Hodgkin's B cell. And you can see that they both had different manifestations, right? So the great masquerader, second to syphilis. The patient on the left has a fairly normal retina, some mild hyperreflectivity, but no full thickness lesions, but really has these big sub-RPE, subretinal deposits. And then the patient on the right has a fairly normal choroidal thickness, a little thick RPE, but no sub-RPE lesions, but has a full thickness retina lesion. So I manage these 2 differently now. I didn't used to, but some of these cases actually kind of guided what I do now. So first for the case on the right. So this would be a case with a retinal full thickness lesion. This is one where I would do a dissection instead of just going straight through with my cutter. And there's a few different ways to do this. So this patient also had a hyaloid that was down. This is a younger patient from Buffalo for a second opinion. Had already actually had a diagnostic vitrectomy that was negative. Oops, sorry about that. So the hyaloid's down. So before I dissect that area temporally, I want to make sure the hyaloid is off the nerve there, off the lesion that I'm going to dissect. Here's my intraop OCT confirming a full thickness lesion. And sorry, guys. So I start by diathermizing the area that I want to dissect. I always diathermize it a little larger than I think because you're always going to get some tissue shrinkage. And I'm pretty aggressive with diathermizing any vessels that are leading up into the lesion. And then I'm sure there's other instruments you could use, but there's really 3 instruments that I can use to start my dissection. One is a vertical scissor, which I love for diabetics and I love for this. The other is you can just use your cutter. If it's a really thick lesion, you can lower your cut rate and turn your cutter into a vertical scissor. And then the third thing that I don't really use because I do 25 gauge, but one of my mentors still does 23 gauge, and he uses, Alcon has a 23 gauge pneumatic vertical scissors, which is pretty cool. You can control the vertical scissor with your foot, with your cutter. So if you use 23 gauge or you have access to that at your institution, that's another technique. So I use one of those 3 instruments. Usually I'm starting with a vertical scissor, and then I'm basically slowly dissecting this path that I created for myself, paying attention to any bleeding that's going to happen. I did pretty good diathermy before, re-diathermizing if there's any blood. And it's important to leave a hinge because you're going to enlarge your sclerotomy to take this lesion out, kind of like an intraocular foreign body. And you're going to get some change in fluidics, and you don't want this flap floating around. So I leave it hinged to keep it in place, adding some extra diathermy. And I enlarge my sclerotomy. And I think these are 20 gauge duet forceps. They're pretty large, but you can use, any serrated or even max grip forceps if you want. I actually would grab more towards the base than I'm doing here. I get a little bit of traction, but I get the lesion and then you can pull it out. You want to make sure your wound was larger than you intended. It comes out nicely. And then you can send that and kind of close up your case. Fluid air exchange through our giant retinotomy there. Add some laser. And then I think I filled this eye up with gas and, patient did well.
That was a beautiful case. The only thing I do a little bit differently is I actually, before I start cutting the lesion out, I will actually laser ahead of time around the diathermy, just because I don't know what will happen in terms of view, if it'll start bleeding. Obviously, you're trying to take precautions against that with the with diathermizing, but just in case, if I have to get out quickly, I've already done what needs to be done under fluid before, or fluid potentially starts forming around the area that you've harvested, and that way you can just go to air, exchange gas, and leave. But otherwise, I do it exactly the same way. Definitely, I think enlarging the sclerotomy is really important. The absolute last thing you need is for the sample to get lost in the sclerotomy or in the cannula or something like that, or it kind of curls up into like a little ball and you don't really get a great specimen that way.
Couple of questions, guys. So I know sometimes people detach the area before starting the diathermy. So the question is, I mean, I know you're diathermizing the retina here. How deep are you going with that? Because I think that's important. Are you diathermizing closer to the choroid to get some choriocapillaris vessels? And as you were going across with the cutter, I mean, you did a beautiful job sort of sliding along the curvature of the eye to not ding the RPE or get a big hemorrhage there. But I know that's harder, obviously, if the retina is not detached. So any tips there, and sort of like elaborate on a little bit about how you did it?
Yeah, I think if you're starting, the vertical scissor is probably a little bit safer than using a cutter, but I definitely do a kind of a full thickness diathermy. Am I really getting choriocapillaris? I have no idea, but I am kind of pushing down, trying to get a full thickness cautery there. And then, when you're coming up, it's important to, just like we learn when we're peeling, but in this case, the eye is even more dome shaped out there. It's important to know that the eye is dome shaped, right? So you don't want your cutter going like, straight in. You want to be kind of going up with the curve of the eye to realize that. And then I know this is hard to teach fellows, and it was hard for me too, but you can kind of feel where your cutter is pushing to know when you're getting to the RPE, and like when you can kind of like back up a little bit, but not too much, and keep cutting. And it's just kind of a by feel thing. But I think it's easiest to start with a vertical scissor. Then I really don't think you have to detach it, but detaching it definitely makes it easier to kind of pierce in and get a cut. By definition, usually these lesions are kind of thick and boggy, and I found that's good enough.
Do you want to show us your other technique?
Yeah, so the other technique kind of guided a big series we did that changed how I approach these cases. So I'll kind of quickly go through it. So this is an 82-year-old white phakic male. So anyways, diagnosed with PVD, 2 weeks later, worse floaters, sent to Rena for VIT for floaters. And as you can see here, asymmetric, quote unquote, AMD. Left eye's normal, right eye has these little drusen. So Retina said at this time, you just have AMD here. You don't need a vitrectomy for floaters. You're good. Get cataract surgery. So he gets cataract surgery, and after cataract surgery, he drops to 2200 in the right eye, and the cataract surgeon looks in the back, sees that there's white dots in the retina, sends him back to retina, and here's how the patient looked. So really important here to see, unlike Ananth's case that we saw in part 1, the lesions are more in the periphery. They're sparing the fovea. Also, look at all these juicy cells. I mean, how would a cytology be negative here, or a flow cytometry? Right? So we decided in this case not to go for the lesions, just go for a vitrectomy. And by the way, when you first look at this picture, you might think, oh, is this an ARN picture? Very fair when you're just looking at this photo. Sent the patient back for another peripheral OCT, and then boom, you can see that this is obviously not a viral full thickness retinal lesion, but instead you have these massive sub-RPE deposits that are asymmetric. They're not peripheral drusen. The other eye doesn't have any. So this kind of made me think in this guy, this is vitreoretinal lymphoma. So, took this patient for a diagnostic VIT, but you got to consider, obviously, as we talked about in part 1, infectious, inflammatory, other neoplastic conditions. So diagnostic VIT, right? All those juicy lesions. Some pearls that Ananth mentioned is obviously you want to avoid steroids if you can. Talk to the cytopathologist. So anyways, negative. So, Ananth walked us through how to do a good diagnostic VIT. We did something similar, and everything was negative for this patient. So we had to go back into the eye. At the time of the diagnostic VIT, we also sent for some viral or fungal toxocultures. So scheduled him to go back in the eye, but this is an older patient. we know probably has lymphoma. And sure enough, that same week, he went to the ER with lethargy, unsteadiness, handwriting changes. MRI brain, which was previously normal, now is not normal and shows multifocal areas of signal abnormality. And even though the MRI is saying this, oncology doesn't want to start treating him because they want positive tissue diagnosis. The option is a brain biopsy or to go back in and get the lesion. LP is negative. So we decide to go back in. So this is about 2 weeks after our diagnostic VIT. And you guys remember how the picture looked. And you'll see a dramatically different eye here. So that's how the eye looks now, 2 weeks later. So it would have been nice if we could have diagnosed this 2 weeks ago. Here, basically, we want to just really, this guy's decompensating. We're just going to take tissue. We want to get a diagnosis so this guy can get treated. Oh, here's a little bit before my kind of algorithm that I explained to you guys developed. But we basically biopsy him here both ways. So this nasal area, even though these days, because it's a sub-RPE lesion, I'd probably just stick my cutter right in there, which we'll do in another area here that we'll go through. I do kind of the same technique I showed before. And here is where you can kind of do our surgeon version of a fine needle aspirate biopsy because we're comfortable with vitrectomy. I raise the IOP. Here I do lower my cut rate to about 800 to 1,000. And this area was so avascular, I don't think I diathermized before, but let's say it was a lesion like at the beginning or maybe Ananth's lesion in part 1 that was more peripheral. I'd add some diathermy B beforehand over and around the lesion. And then with the IOP elevated, aspiration high, cut rate low, go right in and start cutting and take the lesion and add laser around it if you can. Here, very nicely, location-wise, I could aim superior, which is what I prefer to do because my tamponade then will make this area less likely to detach. If you have to do inferior, you have to, but if the lesions are in multifocal areas, I prefer to do it superiorly. So I'll fast forward through this because we already kind of went through the technique, but similar technique here. Really dissecting this lesion, enlarging the sclerotomy, 20 gauge forceps to grab this lesion. And, you know, this whole case had all these white fluffy things floating around. You also saw at the beginning of the case that he had some vitreous debris that was back. And what's super interesting about this case is the results showed that the vitreous aspirate was still inconclusive and inflammatory, but the retina and sub-RPE tissues showed aggressive B-cell non-Hodgkin's lymphoma. So, you know, this case actually led us to look at all of our patients that got diagnostic VITs for suspicion of lymphoma. And we found something super interesting that over 60% of patients that presented with a chorioretinal lesion and not just vitritis had a negative diagnostic vitrectomy. So now if the lesion is in the periphery, I kind of go for it if I suspect lymphoma in the primary surgery because I don't want to waste time. We don't really know why this is, but you know, by the time they have lesions, maybe it's a chronic disease. And those cells, we know lymphocyte cells can become very necrotic, which is, you know, the reason we avoid using steroids if we can before a biopsy. So maybe the lesions become more inflammatory. The cytopathologist just with vitreous and says, oh, it's just inflammation. But the lesions is where the real lymphoma cells kind of are. So yeah, that's kind of my algorithm and stepwise approach for when I do a retinal or subretinal biopsy and how I do them.
Is that manual aspiration so you can take the sample?
Yeah. So I'm kind of like how Ananth showed, I'm unhooking. I'm hooking usually a 5 cc syringe for those and manually aspirating or having my fellow manually aspirate and then sending that specimen to the lab. I'm also refluxing anything that was in the cutter into that specimen cup and sending that.
And then when you peeled the peripheral lesion, in the OCT, it looked like it was subretinal, but it almost looked like a sub-RPE actually. But it looked like it came up when you pulled it away. So do you think the RPE came with you?
I think the RPE came with me there. I think I was going pretty deep and I think the RPE came with me there. Yeah, I'm not 100% sure. The pathologist didn't really kind of tell us what part of the retina was there, but it must have gotten some RPE with it.
Well, at least to know it's possible and you can do that safely. So that's fascinating.
Yeah, I mean, sometimes people take choroid intentionally, which I have fortunately not needed to do in my career, but that'd be a little bit stressful to add that into it. That was a crazy case and very well done. I don't think anyone that I know would have gone straight to biopsying it. So I think everyone would have done the exact same thing you did for that first surgery. It's just kind of a crazy way that it progressed.
Well, this is extremely helpful. And thank you to the both of you for sharing your excellent pearls and wisdom. And that wraps it up for our RetFix and Chill today.
Thanks, guys.
Thanks, guys. You guys do an awesome podcast.